Okay, welcome everyone to this session on mixing up methods in drug utilization research. I'm happy to see so many people here at the end of the day. So thank you for being here. All the presenters, I'm sure, appreciate having such a full audience. We'll get started right away. We have a great lineup and we'll get started with our first speaker, Annika Jodika from Oxford, who's going to talk to us about approaches to standardized drug utilization analyses in the Darwin EU.
Thank you, Andrea, for the introduction. Good afternoon, everyone. My name is Annika Jodika from Oxford, and I am delighted to today tell you a little bit about the approach to standardized drug analyses that we use for Darwin EU. I would like to acknowledge that all the views that are presented in this presentation are those of the Darwin EU coordinator only, and I personally do not have any conflict of interest for this presentation. I'd like to start with a quick introduction to Darwin EU, which is the data analysis and real-world interrogation network that the European Union has set up to generate reliable evidence from real-world healthcare data. And the aim of this big project is to facilitate reproducible, transparent, and high-quality studies to support regulatory decision-making in a very timely manner. The way we do that is we carry out federated network studies using the OMOP common data model. And as of today, there are 10 databases mapped to OMOP that are onboarded for Darwin, so we can use them to conduct studies. We used standardized analytics for a variety of different types of observational study, and those analytics have been agreed upon with the European medicines agencies as part of a catalog of standard analytics. So what is the challenge at the moment to conduct studies quickly without compromising on the quality? I think if we think about the data landscape that we have, particularly in Europe, we all are aware that this is very heterogeneous data. We have different types, different settings, from hospital data to primary care data to registry data, and they all use different types of coding systems, such as ICD-10 codes, NOMAD code, READ codes. And that means that if we want to have a study that is conducted across different countries and data sets, we have to deal with these differences of heterogeneous data. And that often requires bespoke analytics to account for that, which obviously are time-consuming to produce and potentially prone to errors. So the solution that we use for Darwin EU is that we use data that has been mapped to the OMOP common data model. The OMOP common data model is maintained by the Odyssey community and allows us to use standard analytics for different types of studies, drug utilization, disease epidemiology, and we can carry them out across the whole network. The objective of my talk today is drug utilization studies, and I will present the standard analytics according to the catalog for population-level drug utilization studies and patient-level utilization studies. I acknowledge that there are different types of analyses, such as treatment pattern, also covered by the catalog, but not in the drug utilization chapter. To give you an illustrative example, I will every now and then show you some results from the very first Darwin study that we used as drug utilization study, and that looked at the use of valproate in women of childbearing age. Let's start with the first measure that we're typically interested in when we look at the population level drug utilization, and that is prevalence. So we want to know how many people in the population currently use a drug, and for that, we use the whole database population as a source population, and typically require some previous availability of the people in the data set before studies start, typically for 1 year. And we can always restrict, of course, to subpopulations that we're interested in terms of age, sex, or the history of some diagnosis of a condition that we want to study. As for analysis, we look at a period prevalence or point prevalence, and we calculate that as the number of drug users in the population, the source population, at the point of time or during a time window that we're interested in. And obviously, we can stratify these measures for demographics, calendar period, whatever we feel like is relevant for our study. Apart from the code for the analysis, we also have a standardized output, and this is like the first result that we saw for the valproate study that my colleague Albert presented in more detail earlier today, but I just want to focus on like how it could look if we look at the outcome. As you can see, we had 6 different databases: hospital data from Finland, primary care data from, for instance, the UK, the Netherlands, and in Spain. And you can see as part of this graph that there are a high variability in the prevalence of valproate use that we see among young women, and that is basically due to differences in the databases. As for incidence, another measure of population level drug utilization, we usually use the same population, but obviously excuse people who are previously used the same drug, so we get a new user cohort, and we can look at the incidence of drug use over time, and that is again calculated as the number of new drug users divided by the total population shown in person years. Again, stratified analysis were needed. As you can see here, difference for the incidence. So we see while prevalence was like declining a little bit, we see a nice decline, a strong decline in the incidence of valproate use, which is reassuring because of the risk of congenital malformations in young women if they take valproate while they're pregnant or at the point they become pregnant. Looking at patient-level drug utilization, we focus more on the people who now start taking the drug, a new user cohort, and what we often are interested in is the baseline characteristics. How does the cohort of people who start these treatments look like? And apart from taking the typical table 1, we often do a large-scale characterization that is a bit more data-driven based on the vocabulary of the accommodator model. And we summarize patient-level features such as social demographics, comorbidity, or co-medication at the time when people start the treatment, but also before and after. And I appreciate maybe in the back of the room, it's difficult to see because it's a bit small, but this is like one example looking at co-medication, how such a large-scale characterization result could look like. We typically use an interactive web application to display that just because it's so much data. So as you can see in the red box, basically, this is the time, the index date when people start the medication. So you see for the first row, this is valproate. So people didn't use valproate in the year before. This is a new user cohort study. And then we can sort basically co-medication by frequency and look at which co-medication people typically take when they start the drug or before or after. Apart from characterization, we're typically interested in the indication, and we do that usually by looking at recorded comorbidities in the immediate time prior to treatment initiation as a proxy, as I think we're all aware that the recording of indication is sometimes tricky to find out. We have treatment duration, drug dose or drug strength at the time of therapy initiation, and cumulative drug use that we typically calculate and present. There are 2 R packages that have been developed, the incidence prevalence package and the drug utilization package, particularly to facilitate these types of analyses. And they're very nice because they're very well recorded. So they're in CRAN, publicly available. And my colleagues at and MRT were leading on developing these. And they're publicly available, very well tested, and frequently used by us. So in conclusion, we used standardized analytics for drug utilization studies in the first Darwin studies that allowed it to continue, produce the results very quickly. So for the valproate study, from the time of protocol approval to submitting the report, we had 2.5 months, which I think is very nice because we could provide the results to the EMA in a timely manner. And hopefully having these standard analytics will facilitate the timely conduction of these studies in the future within DAWIT, but hopefully also beyond that. All of the Darwin studies are registered in the EU PASS registry. And if you're interested in having a look at protocols, looking at the times of analysis that we're doing or what kind of US studies are coming up, please watch this space. And I would like to use the last minute to thank the whole Darwin EU team for their great work. Thank you all for your attention, and I'm looking forward to take any questions. Thank you.
Great. So the presentation is now open for questions. Please come to the microphone. While people are coming up, I have one.
Great.
Especially the last part when you're looking, I don't know if this is, okay, it's good.
Yeah.
It's on. When you're looking at the drug utilization at the patient level. Medication adherence is incredibly difficult in a single database.
Yes.
How has that been incorporating it into something like Darwin?
So at the moment, adherence is not part of the standard analytics.
Okay.
I appreciate that there is a lot of interest in that and needs, and I personally think this is super important. But I would think at the moment, this is something that, as you said, is probably a bit more bespoke, a bit more tricky, depending on the database. So potentially, if there was the scenario that such a study would be requested, it might be like a more complex study that is beyond the current packages that we use.
And in terms of the cumulative dose, you do have information on dose
We do, yes.
across all the databases.
Across the databases, yes. We
So
have a very nice tool that has been developed specifically for this to look at, we call it drug exposure diagnostics. So we do some quality tests of the data for the drug prescriptions that we want to use for a drug utilization study, just to ensure that the recordings in the database that we use for the drug that we're interested in are well enough to do this analysis. Otherwise, it's better to say we don't do it rather than doing it not right. Exactly.
Perfect. Thank you. And I see the microphone.
Yes, just one question, please. Thank you very much. Some of the variability that you saw in those graphs, how much are you able, or have you guys looked at possible sources for that heterogeneity across the data sources? Is that a factor of the transition to the common data model, the data sources within the countries, actual utilization? Have you looked into that or have any ideas?
Yes. So we were super interested in it when we saw that. And I think for us, the main finding was that this is very different in the different countries because of regulations, but also in the different type of data. We have hospital databases, we have primary care databases, and this variability is less because of the definition of valproate, but more because of the different setting of the data that we looked at.
Thank you.
Thank you.
Maybe a minor technical question for you. When you're collecting patient level data, is there a common term for indication, or it just stands for representative of ICD-10 for your patient level data?
So for this study in particular, we were interested in epilepsy, bipolar disorder, and migraines. So we created a code list or a concept set for these conditions, and then particularly looked for that. Yes. Thank you.
Great. Thank you very much.
Thank you.
And we would like to welcome the second speaker, who is going to talk about using data level registry data to assess heterogeneous and time-varying medication exposure patterns in patients receiving long-term outpatient antibiotic therapy. Our speaker is Madison.
Yes. Hi.
Hi.
My name is Madison Ponder, and I am a third-year PhD pharmacoepidemiology student at UNC Chapel Hill. So yeah, let's get started. Here are the disclosures for this project, including our funding support and conflicts of interest. So outpatient parenteral antimicrobial therapy, or OPAT, are programs for patients with serious infections that allow them to leave the hospital and receive intravenous antibiotic therapy at home, which I will elaborate on in a little bit. But each patient has a number of unique factors that go into the decisions that clinicians make at OPAT initiation. And as the patient continues OPAT, there's a lot of potential for treatment complications or treatment failure. And all of these alter the planned course of OPAT, which ultimately will increase treatment heterogeneity in OPAT populations. With so much potential heterogeneity among exposures, infections, and other health considerations, studying these populations can be really challenging and difficult to communicate findings, particularly for comparative effectiveness and safety studies. So we aim to facilitate classification of these highly heterogeneous treatments and present ways to show these data from a high-level perspective. And typically, the patients in this type of OPAT program have had a really serious infection and they have to go to the hospital for a hospitalization. They spend enough time in the hospital where the clinical team can figure out what's going on. They can diagnose the specific pathogen and come up with a treatment plan for these patients. And over time, their infection will improve and will be under control. And at that point, the only reason they're in the hospital is so that they can be monitored. And at that point, it's usually determined that they can go home and be in a safer place where they're not at risk of hospital-acquired infections or other risks associated with staying in the hospital. So the clinical OPAT team will just follow them up through phone calls, virtual visits, and other types of check-ins. And patient follow-up begins at the time of treatment beginning with the OPAT team for this study. And at most, patients could contribute 70 days. And we chose this into follow-up because it's extremely uncommon for an OPAT planned duration to go beyond 70 days, with most planned OPAT durations at 35 days. So as an example, patient A, we may see discontinue at day 35. We would follow them for another 5 days to confirm that they had discontinued. And then for patient B, if we would end a follow-up at 70 days, even if we know they continue treatment for another 15. We then categorized treatment into 18 hierarchical and mutually exclusive groupings, which were based on the clinical knowledge at our hospital of what's most critical for studying and keeping an eye on during OPAT courses. So these categories came from about 520 distinct cocktails of 64 distinct antimicrobials on any one day of treatment. And if we look at the treatment classifications on the right, we have them listed in rank order and labeled with a color. And these colors kind of help orient to a drug family when we're visualizing these treatments. For example, we have red shading treatments that would be easily identified as vancomycin families, and the pink shades would be easily identified as daptomycin. We also categorized infection diagnoses into 11 groupings. Those are listed here. And finally, we categorized the infectious pathogen based on what was most common and clinically significant, which are also hierarchical and mutually exclusive. We then visualized the patient experience using various figures that represent the burden of exposures among our stratified groups. We also utilized spectrum coverage indices to describe the spectrum coverage of antimicrobials experienced by each patient throughout their OPAT journey. And for our patient characteristics, these patients on average spent about 5 weeks on OPAT. The majority of patients were males at 60%. The median age of patients was 55. Patients had a median drive time of 55 minutes to UNC for any planned or unplanned check-ins. Osteomyelitis was the most common infectious diagnosis. Methicillin susceptible and methicillin resistant Staphylococcus aureus were the most common infectious pathogens. So here's a line diagram with each line representing one patient diagnosed with bacteremia, which is a blood infection. This figure gives you a sense of the varying durations of OPAT, as well as all the variety of treatment going on. And predominantly, we can tell that this figure has a lot of shades of blue making up the treatments. And we know that that's associated with the cephalosporin family. Next, we'll talk about a few examples of patients diagnosed with osteomyelitis, which is a serious bone infection and might look something a little bit like this. And here's that line diagram of patients with osteomyelitis. Arguably, a bit more is going on here. And we can line them up side by side and compare with the bacteremia patients. So you can see there are many more of these patients to begin with. And also it looks like they have a bit longer average durations of therapy, and more treatment changes are happening at the individual level. And I recognize you may not be able to tell super well, but on any one line, there may be multiple colors. And for this group, the colors are predominantly pinks and reds, which correspond to the daptomycin and vancomycin treatment families. The bar chart figures we created can be used to visualize stratifications of interest. So in this example, we stratified by infection diagnosis. Again, we're starting with patients diagnosed with osteomyelitis. The distribution of person time in each treatment classification is represented as a % of all person time for these patients. Again, we see the red and pink is making up majority of this bar, indicating that vancomycin and daptomycin are the predominant families. And zooming out, we can look at all other infection diagnoses as a full mosaic plot where the bar height is proportional to overall person time. Next, we created probability density plots, which represent the likelihood of having an average weekly index value anywhere along this continuous scale. And these were used to visualize the distribution of patients' average weekly spectrum indices within each stratum of interest. And in this example, we are looking at the antibiotic spectrum index, or ASI, for patients diagnosed with osteomyelitis. So we grouped weeks of OPAT into 2-week intervals, where the early weeks were green, mid was yellow, and final were red. And again, I recognize they may be hard to tell, but you can kind of see that all of these lines are right on top of each other. And so this is suggesting that there's a consistent spectrum coverage throughout OPAT. And this makes sense because for osteomyelitis, it can be really challenging to treat and does often go for a bit longer than some other conditions. On the other hand, some other infection diagnoses like skin and soft tissue infections have more variability of spectrum over time, which you can see by this non-overlapping red line that seems to be a little skewed toward the left. And this one may be more indicative of increasing spectrum coverage as time progresses due to treatment failure, because oftentimes it's uncommon for patients receiving OPAT 7 or 8 weeks and beyond for this group. And then here are all the other ones. So in our study, we developed this novel schema of exposure classification for this really medically complex population, which allowed us to take a step back and just clearly look at what is even going on in with these patients. So we were able to improve both classification of heterogeneous treatments and clinically important covariates. So future studies should really keep in mind that within any given stratum of interest, there can be a lot of cocktails that have really important clinical decision-making and policy implications. I'd like to acknowledge my co-authors and the Carolina Antimicrobial Stewardship Program, and happy to take questions.
Let's open for a question from our audience. Well, maybe everyone is still thinking. I'm curious that what is it basically broadly meaning that any clinical implication when you comes up with so much heterogeneous antibiotic utilization?
You're asking about the
taking osteomyelitis as an example, that the variation is quite large and between all the treatment pattern. So when you find out such an heterogeneous pattern, that will you further examine any quality prescribing indication or outcome or anything that relevant to clinical decision?
Oh, okay. Yes. So that this is like the first step for our future studies where we're looking at discontinuation patterns. I actually have a poster for the follow-up that's looking at planned versus unplanned.
Yes.
So things that go into that kind of discontinuation are like hospital readmissions, ER visits, changing levels of whatever particular blood level they're looking at. Those kind of like adverse drug reactions.
Okay.
Does that kind of?
Yes, I think that's a wild direction that can thinking of other. Also, is there any information of your data that if patient get lost follow-up during your observational period within the within their treatment duration in your survey?
To my knowledge, there's not a loss to follow-up. I think if they're discontinued, it's I mean, that's a good point. I should probably double check, but I'm pretty sure they're being followed like very, very closely. The data is being pulled directly from the EHR. But yes, I will double check.
Okay.
I have a follow-up. Yeah. So I have a follow-up to my co-chair's question.
Yeah.
I think it's, I mean, as you said, it's the first step.
Yeah.
And it is a single center
Yes.
site,
Yes.
but yet you see such variation in what's being given, even for the same indication. I'm guessing you've done this, but have you looked at the patient characteristics and also kind of compared it to the guidelines? Because this would also give this idea for future studies around confounding by indication. So why are certain people getting certain antibiotics versus another one? And then does that then change how you look at the outcomes, and how will you even attempt to overcome that if you want to do a comparative effectiveness study? Sorry for the difficult.
No, I mean, we're just starting to look. Like I said, there's so many different covariates that go into these treatment decisions. That's why we looked at pathogens. Like, that's not a word you hear around here a whole lot, but it's truly part of the, this huge number of things that go into the decision to treat a patient. So guidelines, yeah, I don't have an exact answer for that, but we will definitely be moving this forward in that direction, trying to figure out how do you do a comparative, any sort of comparative study with this type of heterogeneity. So
I also really liked the visualization. It's a great way to see your data.
Yeah.
Well,
Any?
if no, then maybe we can go
can
proceed to the third speaker.
Thank you very much.
Thank
Thank
you.
you.
Right, so as we set up the next one, we're going to welcome Mary Ellen to the stage to talk to us about projected impact of weight loss medication use on racial ethnic disparities in adolescent obesity. And the floor is yours, Mary Ellen.
All right, thank you so much. My name is Mary Ellen Vajravelu. I'm a pediatric endocrinologist and health services researcher from the University of Pittsburgh. Thank you to the conference organizers for inviting me to speak on behalf of my co-authors on the projected impact of weight loss medication use on racial and ethnic disparities in adolescent obesity. Our only disclosure is that two of our co-authors are employees of the Department of Veterans Affairs in the U.S., and the content of this presentation does not necessarily reflect the views of the Department of Veterans Affairs or U.S. government. As most of us are aware, pediatric obesity is an unfortunately common and complex chronic disease. It currently affects over 14 million children and adolescents in the U.S. and is projected to affect over 250 million children worldwide by 2030. The prevalence is increasing not only in terms of the definition of obesity at the 95th percentile for age and sex, but also extreme obesity. So these are children with a BMI that's at least 20% higher than that 95th percentile, so extreme obesity. Unfortunately, there are also significant racial and ethnic disparities in obesity prevalence, with non-Hispanic, Black, and Hispanic children having significant rise in obesity even as early as kindergarten and 5th grade, and these disparities persist throughout childhood. This has led to severe complications that emerge in childhood, including type 2 diabetes and fatty liver disease, which are being termed epidemic. And these also have disparities across racial and ethnic groups. Type 2 diabetes is a unfortunately significant example of this, with Black youth and other youth of color having significantly higher incidence and prevalence of type 2 diabetes than white youth. In this setting, the American Academy of Pediatrics released clinical practice guidelines in January of this year about the treatment and evaluation of children with obesity. But the most significant piece of this clinical practice guideline was the recommendation to begin using weight loss pharmacotherapy in children as an adjunct to health behavior and lifestyle treatment, so children as young as 12 years old. This was met with a lot of scrutiny and controversy. Many people were concerned that this will increase weight stigma and disordered eating behaviors. But it was introduced in the setting of increasing availability and approval of weight loss medications for children. So 2 decades ago, orlistat was the first medication approved in children for weight loss. But more recently, 2 glucagon-like peptide-1 receptor agonists, liraglutide and semaglutide, were approved for use in children and represent a paradigm shift due to their improved efficacy versus orlistat. And so it was soon after the approval of semaglutide for youth that the AAP released their guidelines. So with this setting, we wanted to understand how these guidelines might impact the prevalence of obesity among children, and specifically how this could impact racial and ethnic differences in obesity, given known disparities in uptake of this class of medications. For this modeling study, we used the U.S. National Health and Nutrition Examination Survey, or NHANES, with cycles from 2011 to pre-pandemic 2020. And we included adolescent participants who were between the ages of 12 and 17. We used this data to calculate a post-treatment BMI, so assuming the same efficacy as semaglutide, to calculate a reduction in BMI. And we varied uptake from 10 to 100% and then recalculated the prevalence of obesity with this new BMI. We also applied real-world race ethnicity disparities in uptake of this same class of medication that has been previously shown in adults with diabetes. The medication that we used as our model for a highly effective medication was semaglutide, and this was based on the STEP-TEENS trial that was published last year and was led by Novo Nordisk. This looked at semaglutide 2.4 milligrams once weekly as a subcutaneous injection, and it found that there was a 16.7% reduction in BMI versus placebo over 68 weeks. And this is a really significant BMI reduction. And another way to think about this is in terms of body weight percentage decrease, and 73% of the youth who were in the treatment arm had a reduction of at least 5% of their body weight. So a highly effective medication and really a game changer for pediatrics. The disparities that we applied were based on a study of commercially insured adults with type 2 diabetes who were eligible for glucagon-like peptide-1 receptor agonist use. And this study demonstrated that compared with white adults, Hispanic, Black, and Asian adults had 8, 11, and 40% lower uptake of this medication. So for our study, we included over 4,000 adolescent participants, which translated to over 26 million adolescents when applying appropriate survey weighting. These participants were representative of the US population in terms of race and ethnicity, with about half non-Hispanic white, followed by Black and Mexican American representing about 15% of the population each, and lower percentages for other Hispanic, Asian, and multiracial youth. The overall obesity prevalence was 22%, but this varied widely, with about 11% of Asian adolescents having obesity and 30% of Mexican Americans in the obese category. As you would expect, with increasing uptake of this highly effective medication, the overall obesity prevalence would be anticipated to decrease from 22% to around 10%. But this decrease is really felt differently across the racial and ethnic groups. So as I mentioned, Mexican American and Black youth have the highest baseline prevalence of obesity, with other racial groups falling lower than that. What's important to think about is how many youth would need to be treated in order to achieve even the baseline average. So for the 2 groups with the highest prevalence at baseline, for example, non-Hispanic Black youth, about 1/3 of them would have to be treated to even achieve that baseline average. And about half of Mexican American youth would have to have uptake of this highly effective medication to even achieve the average baseline for American youth. We also looked at the relative prevalence of obesity. So for this, we divided the prevalence of each group over the prevalence of non-Hispanic white youth, taking into account the fact that the prevalence would decrease with increasing uptake. So as more youth shift from obese to overweight, the prevalence will decrease. But unfortunately, since so many of youth, non-white youth of color, are already in the obese category, more of them remain in that obese category. So what happens is that the relative prevalence of obesity would increase over time. So in conclusion, even though absolute obesity prevalence would be expected to decrease with increasing uptake of these medications, this could lead to a widening disparity in relative prevalence. So essentially more youth of color or youth in groups who are not having uptake of this medication remain obese while other youth shift into the overweight category. So what we need to address is not only pharmacoequity, but primary prevention and policies to address some of the social determinants of health that underlie pediatric obesity. So currently, we are in a state of inequality, especially in the United States, where coverage for these types of medications differs by insurance type. If coverage were equal, we could say this was equality, but what we should strive for instead is equity. So we need to not only make coverage equal, we also need to facilitate uptake and make sure that youth who are at highest risk are able to access these highly effective medications. But ultimately, what we need to do is prevent these disparities in the first place. And as I showed, due to the very large difference in obesity prevalence at baseline, we have a lot of room to go. So thank you very much. Welcome any questions.
Thank you very much for a nice presentation. The floor is now open for questions. And I'm going to take moderators' opportunity to ask a couple from my side. I was curious also, I mean, I don't know much about the use of these drugs in the pediatric group. I mean, I know they're still under testing. In the adults, it's been recommended generally to have it, I think, for 2 years in terms of duration for obesity. What would be the knowledge within the youth population? Is it the same kind of idea, short term, and then you could move off of it, or is it actually a more longer?
Yeah, that's a really excellent point. There is no endpoint,
Okay.
which is the really sad fact. And once patients are put on these medications, there's no clear endpoint. I think most people want to use it as a bridge, but we don't have the data to really show when you can safely come off it.
Okay. And I have maybe a broader
Mhm.
question. In general, I mean, the aspect around obviously the racial and ethnic differences is very complex and goes a long way. But just from a general standpoint, do you know if there's any evidence in the effectiveness of the medications in different racial and ethnic groups?
That's an excellent question. I don't think that data has been published, and I assume
know.
they will look at it. But one of the limitations of these studies is that there has been lower enrollment for certain groups who are at highest risk. So I think coming to conclusions about that is very difficult. And I think we are going to need some real world data eventually, but I don't think we have that yet.
Okay. I think it's very interesting.
From your observation, that how would you suggest that to promote a dietary behavior, because it's so cultural related and so also relevant to obesity, not just the pharmacotherapy itself?
Yeah, absolutely. I mean, I think it's a multifactorial treatment. We can't rely on medications. Medications are not going to be the answer for pediatric obesity. That's why we need to prevent it in the first place. But we have failed to do so far. So I think we need a lot of policy changes to take place. But we're far from that right now.
One more. Sorry, this is a very interesting topic for me, so you're stuck with me for another question. In terms of the access, and I think we will have another question, what would your kind of holistic look, because of course these are still expensive drugs, and this is a big issue when you come to racial diversity and overcoming that. So just your quick thought on how you would overcome it.
I wish I had an answer. I don't think we have an answer. So I think, and honestly, as a clinician who has prescribed these medications, It's an important discussion for sustainability, right? Because if you prescribe a medication like this that is very expensive, difficult to access, not sustainable, that's not a good solution either. So I think the medications have to become cheaper at some point, have to become more accessible. We are definitely not there yet. But I think that's going to be a limitation in the real world uptake, and it's probably going to worsen disparities before things improve, because people who can access the medications are going to be the ones who have the highest uptake.
Thank you.
Yeah.
To the microphone.
Sure. Great presentation. Very interesting. I was just wondering, could you speak a little bit about the modeling aspect of your study? And I'm not super familiar with the details of the NHANES data, but do you think there's like limitations at all around the like differential misclassification amongst your groups, or any evidence for that in terms of the reliability and of obesity being measured?
In terms of the BMI measurement, or
Yeah, I guess was that your main input, or I guess, yeah, I don't, just trying to, maybe you could speak to some of the limitations in your modeling study, particularly with the BMI data, and if there's any differences among groups that you think might be contributing to your results.
Yeah, so I think actually NHANES is probably the ideal data set for this, because they do reliably measure BMI. They do weight, they have medical exams for these patients. So that's what the BMI data was based on. So all we did was we took that BMI data and then applied the 16.7% reduction. So it was all based on measured BMI.
Perfect.
Yeah.
Thanks. I wasn't sure.
Thank you.
Thank you.
Yes.
Thank you.
And now let's move on to the first speaker. And the first speaker will present their study on approaches to the description of patterns of care after colitis diagnosis in melanoma patients treated with immune checkpoint inhibitors. And we have Xiangyin going to present the topic.
So how to move? Just insert here. Thank you. Hi, hello everyone. My name is Xiangyin Pan from Bristol Myers Squibb. I thank you for taking time to come to this presentation at this late afternoon. Nowadays, we probably all have very busy schedules. So, given that, when we try to capture information or message from data, we want to get those information and message quickly and easily. So we at the BMS, at the Bristol Myers Squibb, we put some efforts on this. We'll try to get some approach to gather those information quickly. So today I'm going to present the approaches that we used in our study to generate and also present data in a way that is easy to read and easy to memorize. Here's the disclosures. A little bit background. Immune checkpoint inhibitors have revolutionized the treatment of melanoma and other cancers by modifying the body's immune response. Despite the effectiveness, ICIs can cause immune-related adverse events such as colitis. The timing of colitis onset, how to treat colitis, and also the duration of treatment. Those data from real-world practice could be important for both patients and also healthcare providers. So we're going to share the approaches that we used in our study to generate and also present this type of data. First, we used the Kaplan-Meier method to visualize the timing of colitis onset. Second is to use the Sankey chart approach to illustrate the medication treatment patterns. And the third is to use Kaplan-Meier method to present the duration of corticosteroids treatment. This study is a retrospective cohort study. We
we used the data from IQVIA Pharmaceutics Plus Claims database. This is a cohort of melanoma patients who received the ICI treatment and also subsequently developed colitis. The study period is from January 1st, 2016 to June 30, 2022. Here is a list of inclusion and exclusion criteria that we used to identify patients from this claims database. Here's some key definitions. In this study, the index is the date the patient initiated a ICI treatment. And we also require those patients have melanoma diagnosis within 5 days before on index date. The follow-up period in this study is from index date to either the end of continuous enrollment or the last ICI treatment day plus 100 days or the end of study period, whichever comes first. The colitis events were identified during the follow-up period. We require patient have both colitis diagnosis and also the treatment. The treatment is required received within 30 days after colitis diagnosis. And also we require patient have at least a 1 year baseline period to capture the baseline characteristics and also exclude those patients who have colitis diagnosis during the baseline period. Here's the colitis medication we included in this analysis. It includes 5-ASA, corticosteroids, biologicals, and also JAK inhibitors. The analytical approaches we used in this study is Sankey chart approach and also Kaplan-Meier method. In this study, we included 347 melanoma patients who initiated ICI treatment and also developed colitis later on. And in this cohort of patients, 55.5% of patients were male, and the average age was 55 years old. And also the majority of patients in this cohort were at metastatic cancer status. It means advanced stage of their melanoma. The right side is the patient selection flow. I'm not going to go to the details. Here's the baseline patient characteristics. As I just mentioned, majority of patients had metastatic cancer, and also a lot of patients have hypertension, anxiety disorder, obesity, liver diseases, and also the other comorbidities at the time that they initiate ICI treatment. We also have age distribution here. Around 50% of the patients were in the age group from 45 to 60 years old. Here is the medication treatment patterns. This product we generally using Sankey charts approach. In this cohort of 347 patients, 320 patients who started with corticosteroids treatment, and around 1/4 of the patient later also received the biologicals or 5-ASA. And there are also 5 patients received a combination treatment, started with combination treatment of biologicals or corticosteroids. And the 12 patients started with biologicals, 5 patients started with 5-ASA, and the 2 patients started with the combination of 5-ASA and corticosteroids. Among the 4 class of colitis medication, corticosteroids is the class that most frequent prescribed in this cohort of patients. And among corticosteroids, prednisone is the most frequently prescribed medication. And among biologicals, infliximab is most frequently prescribed medication. In this cohort of patients, majority patients started with prednisone. Here is a graph to present the timing of colitis onset. This plot is also generated using Kaplan-Meier method. From this graph, you can find around 80% of the patient who had colitis events within 10 months from the ICI initiation. And also around 24% of the patient had a colitis events within 2 months after ICI initiation. And the median time from ICI initiation to colitis onset was 4.2 months in this cohort of patients. This graph represents the duration of corticosteroids treatment. The plot is also generated using Kaplan-Meier method. From this plot, you can find around 86% of patients who had less than 10 months of corticosteroids treatment, and around 40% of the patients have less than 2 months of corticosteroids treatment. The median duration of corticosteroids treatment in this cohort of patients was 2.7 months. A little bit summary. So in this cohort of patients from real world practice, the median time from ICI treatment to the onset of colitis was 4.2 months, and the median duration of corticosteroids treatment was 2.7 months. Within the subgroup of patients who received first-line corticosteroids treatment, 77% received no further therapy. However, 23% were subsequently treated with biologicals or 5-ASA, suggestive of possible inadequate response to corticosteroids. And we also observed 20 patients, around 6%, were administered biologicals initially. To conclude, the Sankey chart approach and also the Kaplan-Meier method are useful tool to describe the to illustrate the medication treatment pattern, and also the timing of colitis onset and the duration of corticosteroids treatment. Thank you for your attention. I would like to address any question you might have. Thank you.
Now we have question from audience.
Hi, my name is Ravi Botravelu. I'm from Division of Gastroenterology and at University of Pittsburgh and VA Pittsburgh Healthcare Center. So did you look at time trends for the treatment patterns in your Sankey diagrams? You know, at the beginning of your cohort in 2016, you know, the clinical knowledge about these immune checkpoint inhibitors was very little. We were hesitant to treat patients. And then over time, with more people being treated for more conditions, we're more aggressive in the treatment, and you're seeing more people going straight to anti-TNF therapy, anti-integrin therapy. And so you had commented about how you had 20 patients who had gone straight to biologics. I'm curious how that plays out as you stratify time.
That's a nice question, but in terms of trend, we haven't taken a look, but it's nice suggestion. We'll take a look later.
Thank you. Jeff Curtis from University of Alabama at Birmingham. I appreciate your presentation. So a little bit following on the time trend idea. So getting a biologic or other targeted therapy and not just steroids is rather conditional on you seeing a gastroenterologist. And so I'm curious, did you look at referrals to GI doctors? Because I suspect that oncology may have just managed a lot of GI symptoms that might not have been coded with your K50, 51, and 52 outcome codes. And most of those people probably just got prednisone or other steroids. And I wonder if this actually might be a bigger problem than you found, but nobody coded it as colitis because it's only a GI doc that's more likely to do that.
Yeah, we probably, in our approach to identifying patients, we'll look at like both diagnosis and the treatment. So for those patients without the diagnosis code, probably missed in this study. But what maybe think further, see if we have a better approach to identify patients.
I personally is not familiar with melanoma, but I'm just curious that how about the disease progress itself will also result in complications of colitis, not even without the treatment of immune checkpoint inhibitor.
You mean melanoma
Melanoma itself, the disease itself, well, it also like during its say metastasis may also cause a complication of the colitis. Would
I mean,
it
like
be?
the background background rates.
Yeah. Right.
Yeah, it's possible that the disease itself can cause colitis. But in our study, we're more focused on
of course it's not, but
yeah.
if it is possible, would be good to look at because in previous treatment there is not available of immune checkpoint inhibitors. So
yeah,
in previous profile and previous
yeah, it's like a background rate.
then
Yeah,
probably
we
can have some background.
Actually, we it's like we did a lot like to compare the background rates in patient without the ICI treatment and also patient with ICI treatment. This is not our focus in this study, but we do a lot of that type of analysis. I think it's kind of obvious, like colitis will cause, and the ICI treatment will cause colitis. We looked at the data. If a patient without the ICI treatment, the colitis events will be lower. Yeah,
that's right. That's right. Yeah. Yeah. Thank you. Yeah.
Thank you.
Yeah. Thank you.
Great. So we'll move on to our next speaker, and we're going to have Michael Munsell talk to us about characteristics of U.S. middle-aged adults with polypharmacy, an unsupervised machine learning approach. Good question. I don't think it's actually all tools. We don't need that. Just the next one. Oh, there we go. Screen.
Hi, everyone. I'm Mike Munsell. I'm the Director of Research at Penalgo. And as introduced, I'll be discussing our work characterizing middle-aged patients with polypharmacy using unsupervised machine learning. Here are my disclosures. So polypharmacy or multi-medication use is typically evaluated among an older population. And this makes sense given higher likelihood of multiple conditions as well as multiple treatments to manage those conditions. But the adverse events of polypharmacy, various drug-to-drug interactions, hospitalizations, those are applicable really at any phase of life. And when we look in the literature, middle age, so the age right below an older population, typically are not included in these types of analyses. So even quantifying baseline characteristics like the types of treatments you're seeing for patients with multiple treatments and the conditions associated is moving in the right direction of further research in this area. So the objective of our study was fairly simple, is to identify and describe treatment combinations and conditions commonly associated with outpatient multi-medication use in middle-aged US adults. So for this analysis, we had 2 years of de-identified insurance claims data, where we required patients to have continuous enrollment in a health plan during those 2 years, as well as be between the ages of 50 and 64 during that time period. In line with the literature on polypharmacy, we required at least 5 unique medications that are simultaneously prescribed, and we required at least 60 days of concurrent treatment. So 60 days was selected in this kind of more exploratory analysis, just to have more than a month's supply, but also we didn't want to necessarily restrict this to chronic conditions only, since we were trying to understand the population a little bit more. And all analyses were implemented using the Instant Health Data Platform. So in wanting to kind of approach this evaluation of treatment combinations in a hypothesis-free way, we needed to rely on other methods. So we used unsupervised machine learning. So if we're looking at the literature of what's already out there, we didn't necessarily want to just look at the treatment combinations that are known for an older population within this population, given that we could miss some interesting facts about the middle-aged population. So we specifically used the k-means clustering algorithm to help us identify the optimal grouping of data within our data set, given the set of patient characteristics that we had. And in this case, it was all of the individual treatments that were prescribed to the patients during their period of polypharmacy. So this unsupervised machine learning approach essentially gave us a way to explore the combinations of treatments without defining those combinations a priori. So we had over 40,000 patients in this data set of this age that met the polypharmacy criteria, and at the start of the study period, average age of around 58. So similar to an older population that you're viewing polypharmacy in, statins were the most commonly prescribed medication within this treatment group, and that makes sense given their high prevalence of hypertension and also hyperlipidemia. We also saw a high prevalence of diabetes. So you're seeing the guanides or metformin also in this population. So these are just some high-level individual treatments that we were seeing within this group of patients. But to note, there were over 700 unique treatments identified in this population, and also each patient on average had 8 unique treatments. So the permutation and combination of all of these various types for exploration was fairly computationally expensive, which is why we implemented the method that we did with unsupervised clustering. So the optimal cluster yielded 2 groups. This was based on the silhouette coefficient, which you can compare different cluster methods to see what the best separation is. And the treatments that were defining these cluster assignments were narcotic analgesics. So this included opioids as well as opioid combinations, glucocorticoids, and also benzodiazepines. So these importances, this is based on intercluster variance. Essentially what that is you're looking at each of these clusters, seeing the prevalence of each of these treatments within the clusters, and then looking at the variance across clusters. So a higher intercluster variance score is effectively saying that you have better separation among the groups. So these were just the top 3 in the list. All features are in this model evaluated and ranked as such. So for the blue cluster, what we're calling cluster 2, these patients had a high prevalence of each of those 3. So the intercluster variance was primarily describing how to be categorized within this cluster. Looking at the combinations too, the most prevalent combination was opioids and benzodiazepines being co-prescribed in this group with around close to 50%. The other cluster, with how this is set up, it's essentially is defined by not having those treatments or a low prevalence of those treatments within the group. But in looking at what the most common prescriptions were for that group, it was statins and metformin, which is similar to what we have seen in the older population as well. So this unsupervised machine learning approach gave us a starting point with this group of patients that we had not evaluated before of what would be the next step for meaningful treatment combinations to look at. And so we had one population with statin and metformin, and the other with opioid and benzodiazepines. So, and then pulling out and kind of looking at this full sample of patients of middle age with polypharmacy, around a third of them were being treated with statin and metformin, and most of them for a longer period of time. Around 1 in 5 patients in the full sample had a receipt for an opioid or a benzodiazepine at some point during the 2-year window. 7% had them co-prescribed concurrently for at least 60 days. So them meeting kind of that criteria that we used to pull them initially. And so that's around 3,000 patients in this data set, smaller in comparison to the statins group, but meaningful given that these two being co-prescribed for a length of period of time is somewhat unwarranted in some guidelines. And what we're seeing for those patients who were being co-prescribed, close to 10 months in duration for those being co-prescribed at least 60 days. So kind of pulling back and thinking about our initial research question here and taking what we found, compared to the older population who has multi-medication use, we're seeing a group around 35% of this sample matching that criteria where they have hypertension and diabetes and metabolic conditions, as well as obesity, and they're being managed with these treatments over a long period of time. The unsupervised machine learning group that was pulled out is effectively in line with pain management. So these patients did have hypertension commonly within this group, so statins were prescribed, but you're also seeing muscle relaxants, and the most common diagnosis being neck pain within this group. One thing that was also interesting is that we did see a high prevalence of antidepressants also being prescribed during this period of polypharmacy for these patients as well. So the general limitations in this analysis, so we are using administrative claims data. A prescription fill does not necessarily mean the medication was taken. So there's a chance we're overestimating exposure in this case. We're also subsetting to a commercial population with at least 2 years of continuous enrollment. So these patients have better access to care, as well as potentially a higher socioeconomic status than a general population. But what we're able to at least articulate at this point was that close to a third of patients of the middle age are similar to what we're seeing in an older population with chronic conditions that are being managed, such as hypertension and diabetes with long-term care. But we're also seeing a subset of pain management with patients being co-prescribed benzodiazepines as well as opioids, and commonly, at least in this group, with a diagnosis of neck pain. What we'd like to do moving in, obviously this is kind of a first pass, and this optimal clustering exercise effectively pulled out the most prevalent group and kind of an outlier. There's a lot of groups potentially in between this, and within each of those clusters, you can further kind of separate the data and see what else is there. But this as a starting point was a good baseline for understanding potentially inappropriate and appropriate prescribing among this group, and descriptively providing some initial insights. Thanks for your time.
Thank you very much for the nice talk. The paper is open for discussion.
Hi,
Hello.
Jay from Merck. Curious if you excluded kind of end of life care for patients, so some of that kind of severe pain management at terminal care.
Yeah, that's a great point. So we did exclude in here. Our exclusion criteria included any primary malignancy, pregnancy, and death, and we didn't do that at first in kind of exploration and seeing that it was essentially dominated by end of life care for and also management for cancer and various ones. So that was included in our exclusion criteria for that reason as well. Thank you.
Thank you for the talk. I wanted to ask, how was your feature representation encoded, and like what distance metric did you end up using for your unsupervised learning?
Yeah, so this was just they're vectorized and they're binary, and we were just using Euclidean distance. So it's a very standard, and you could go, even with this, there are we could have gone beyond k-means kind of for the initial pass. That would be better with categorical variables. This is such a kind of, I don't want to say obvious conclusion, but I think this kind of initial pass was a good exercise with k-means. But if we wanted to go any further, we'd probably look at even introducing other variables, but kind of varying the clustering method to see how consistent some of the results were.
Yeah, I think density-based clustering would look really good on the representation there. So yeah.
Yeah, that'd be good right next. Thank you.
As others continue to think, maybe I can ask one. So right
Sure.
now, do I have it correct that you put it in based on kind of ATC, like class level in terms of drugs, like all statins, or were they individually so that you could start to assess those actual drug interactions, because you would want to look beyond the
Right.
class
So this is
level?
an NDC code level to kind of, get at more of that level. We did at that high of a level is a little bit harder to do the clustering in that
Okay.
sense with more data. So yeah, so that level is at the NDC level.
Okay, that was going to be my next question on
Yep.
trying to get that clustering
Yeah.
down.
Thank you.
Can I maybe then ask the bigger question? Because it was in terms of that to go to inappropriate prescribing and using this as a measure, but this would really require, every statin can be metabolized differently. So the appropriateness of the potential for interaction would really depend going one level down. Would you see the next step to either try to get it so you could apply a different clustering method at the individual level, or maybe then just focus on a subset of medications that you would be interested in a priority to look at these?
Yeah, so that's I think initially the thought would be to continue on with the combinations define a priority from this exploration. But I do think, at the heart of right, the inappropriate versus appropriate prescribing and kind of getting into that, we would have to rely on a less of a hypothesis free approach for that as well. So this kind of just more of essentially with this group and evaluating all the permutations of the potential treatment combinations, more of a descriptive starting point. But I do think kind of once that's understood, relying on more hypothesis driven approaches and traditional methods might be where to go with the appropriate versus inappropriate prescribing.
Thank you very much. And no final questions. So we'll thank you for your nice talk, and we'll move to the last speaker.
Thank you.
Okay, so let's move on to the next speaker. Alan is going to present assessing the performance of group-based trajectory modeling method to discover patterns of medication adherence.
This isn't yours.
No. Let's use this space one. Right. Hi, everyone. Thank you for sticking until the bitter end. My name is Alan Gupta. I'm research principal at Cytel. And I'm going to talk about GBTMs and assessing the performance of group-based trajectory modeling for patterns of medication adherence. I do want to mention up front that actually a lot of this work was done by Awa Diop, whose name I've underlined here, who unfortunately could not be here today to talk to you about this in person. So you can think of me as a proxy, and I'm going to be channeling Awa as I speak about this topic. Nothing disclosed. So quantifying medication adherence obviously is really important in pharmacoepidemiology, and in the field that I come from, which is comparative effectiveness research, it's really essential. It's a key determinant of treatment success and healthcare burden. And so we want to quantify medication adherence. The Pharmacy Quality Alliance, or the PQA, which is a body in the United States, has endorsed proportion of days covered, or PDC, as the primary method of estimating adherence. And essentially how we calculate that is fairly simple. It's just a mean. So for example, let's assume that a patient is prescribed a treatment regimen where he or she is supposed to take a dose of drug daily over some time period. And we're interested in calculating the PDC over a follow-up period of 1 year. And the patient actually fills their prescription claims for only 6 months out of the 1 year. So the PDC would just be 6 months divided by 1 year, which is 50%. As you can imagine, the PDC is kind of a bulk metric. It's a deterministic metric that cannot capture the complexity of a dynamic phenomenon such as adherence. So I'm just showing you an example of adherence probabilities or adherence trajectories for two hypothetical patients, where patient one initially has low adherence to the treatment that was assigned to them at time 0 at the beginning of the follow-up period. And for patient 2, initially, they have high adherence, but perhaps because of some toxicity that's related to the treatment, their adherence decreases over time. Now, patient 1 and 2 have very similar or identical PDCs, but clearly very different behaviors. And you can imagine for some indications or some settings, they would have very different outcomes as well. So instead of the PDC, group-based trajectory modeling, or GBTM, is increasingly being proposed as an alternative to better capture the heterogeneity. And so I'll give you a little bit of the formalism. Essentially, it's a finite mixture model. And let's assume that we have data for patients in the form of sequences over time for each patient of, let's say, a binary variable that says prescription filled. And for the sake of assumption, let's assume upfront that there are J groups. We know that there are J, more than one, groups of patients in the population with respect to medication adherence that we want to classify these patients into. And so the GBTM models the probability, the marginal probability of the data, the sequence of the adherence sequence for each patient, as the sum over the product of pi j, which is the probability that any random patient from the target population belongs to the jth group, times the probability that the patient under consideration, the ith patient, belongs to that group. And essentially, this is usually a parametric model of some kind. And so you would model the probability, let's say, of pi j as a multinomial distribution and set up the likelihood, and then solve that using maximum likelihood estimation. Another approach is a non-parametric approach. You heard a little bit about k-means in the last talk as well. In this case, this is longitudinal data, so there's a longitudinal version of k-means. And k-means is just a clustering algorithm. It is not based on, you don't have to specify a distribution for your data. It is simply an iterative approach that starts with some kind of random initialization to minimize within cluster variance given some user-specified distance metric, like the Euclidean distance. So the overview of this study was to compare the performance of GBTM, PDC, and KML at being able to classify patients into their trajectory groups using simulated data, where we actually know what the underlying true trajectory groups are. I'm not going to go into details about the actual simulation process, but I do have some examples of the trajectory groups that we specified. So on the top panel there, those are the true trajectories for when we specified 3 underlying trajectory groups, and we would sample some sample size of patients from this underlying distribution. And then we also have it for 5 trajectory groups. And for 5 trajectory groups, you can see that some of the trajectories are actually very close together. And so the hypothesis going in would be that it's actually difficult to distinguish patients between those 2 classes or 2 groupings. And so essentially, we compared the performance, as I mentioned, of GBTM, PDC, and KML using the metrics at the bottom. So we looked at absolute bias, which is just the difference between the true adherence minus the estimated adherence. And then to compare different models, we looked at relative bias. So the relative bias, for example, for the PDC versus the GBTM would just be the ratio of their absolute biases. And so if the relative bias is equal to 1, then essentially the GBTM and the PDC perform equally well. They have the same amount of bias. If it's less than 1, then you have the denominator is larger, so you have the GBTM having a greater amount of bias than the PDC and vice versa. And we also looked at relative variance, which is just a ratio of the variance. And what I'm not showing you here, I'm not going to show you in the next few slides, is the C statistic, which we used as a measure of the classification performance of these groups of methods. So here are the results for 3 trajectory groups. So on the left is the case where we sampled 500 patients, and on the right we have 1,000 patients. And each table represents essentially the comparison of GBTM versus PDC. So on the top, for example, it's the PDC versus GBTM, where we have specified a linear specification for how we model time in terms of the relative variance, which is RV, and the relative bias, which is RB, for the 3 treatment groups. So just kind of going over the entire set of numbers here, the trends that we saw was that on average, we found that the GBTM actually had lower bias compared to both PDC and longitudinal k-means for both sample sizes and generally for more flexible specifications of time. Usually we wouldn't use a linear specification for the GBTM. What you may also notice is actually the relative variance was actually higher for the GBTM compared to the other methods. And we think that's just because of the bias variance trade-off. As you recover a little bit of the unbiasedness, you have to give up some amount of variance. We performed the same experiment for the case with 5 trajectory groups, and we found a similar trend. The GBTM outperformed in terms of the relative bias, both PDC and KML. And particularly in the case where we had, in this case, groups that were very close together. So in this case, I've marked them with a red arrow. So groups 2 and 4. Actually, particularly even in those cases, the GBTM model actually outperformed PDC and KML. So just as a summary of the results, GBTM showed lower relative bias even when the models were misspecified compared to the specification. When the trajectory group distinction was unclear, all methods showed biased adherence estimates, but GBTM had the least biased estimates, and the results were consistent using the C statistic based on data that I haven't shown you. So just to conclude my talk, GBTM outperformed PDC and KML, in our experiments. GBTM offers the advantage of allowing the user to define the relationship between the treatment trajectories and time, which is not possible with the deterministic approach PDC and the non-parametric approaches KML to a large extent. Deterministic approaches such as PDC rely on fixed rules to create groupings without considering statistical variability, which underestimates the variability. And you saw that in the relative variance estimates. And for the future, we're looking into Bayesian GBTM to incorporate prior knowledge of adherence trajectories, which hopefully will result in better clustering and more clinically relevant groupings. That's all for my talk. Thanks very much, and I'm open for questions.
Good afternoon, Michael Simon, Exponent. Firstly, thanks very much for the presentation. I just have this may be a little off from what from the test you ran, but one of the issues I found with PDC is dealing with folks like the transitions between medications, especially as you may have multiple prescriptions running concurrently. Individuals may maintain multiple supplies because they've been swapped between medications. Did you find if GPTM offered any advantages over PDC when dealing with that kind of situation?
Yeah, I mean, I think as far as I know, I think for the simulation study, we didn't necessarily simulate that scenario, but that's an interesting kind of scenario I think we should look into. I think we want to replicate this with actual data in the future. And that's probably a problem that we'll encounter then. And so, yeah, definitely an interesting point.
Great, thank you.
Thanks.
If there's no other question from audience, I would like to learn a little bit more on trajectory modeling. What do you think of if we increase the number of variables, and would that be possibility compromising your grouping?
The variables in terms of, you mean patient covariates, for
Yeah,
example?
patient, yeah. When you say you're grouping into 3 or into 5, or sometimes in more complicated situation, we may grouping in more.
Yeah.
But if we have want to put in other more variable for the trajectory, then the number of variable, how would it affect your grouping?
Yeah, I think when you put covariates into the model, you essentially make membership into groupings dependent. You're specifying that as a function of patient data or patient covariates. So especially, I mean, if you include time varying covariates, then group membership can change as a function of time evolving covariates. Now, in terms of how that affects groupings, I mean, I think it would change from the base case. In terms of how that would change, I mean, I think that would be a function of the data, but in terms of whether that affects bias, I mean, certainly if the hypothesis going in is that patient health affects adherence, which is probably true, then I'm assuming that including covariates into the model actually improves trajectory, identifying trajectories for patients.
And I maybe have one question for you.
Sure.
So it's new to me, this group-based trajectory modeling. I understand the PDC quite well, and I think it's great that you're challenging the PDC in general. I'm curious in thinking about the next step of it in terms of how adherence has been put into a lot of different outcome research. So for example, we often see that having adherence above 80% is associated with better outcomes. And I agree, it doesn't take into account all these trajectories. How would you then see like the group-based trajectory modeling? How does this fit? It would be then looking at patients that have a trajectory starting high, then low, have different outcomes. What does this look like for the future of putting it in?
Yeah, so the way that these models work is that they identify some groupings, and you will always identify a grouping because when you run a model, whether those groupings are actually clinically meaningful is really, I think, what we are interested in. So I think to kind of validate the groupings that the models identify, what we ideally want to do is try to make sense of them based on clinical knowledge and domain knowledge, but also compare the outcomes in those patients in different groupings. And if they are clinically meaningfully different, then perhaps the groupings that the models have found have some use. Whether they represent the truth, who knows, but they have some practical purpose. And so I think that's where especially with sort of identifying patient heterogeneity in terms of medication adherence can help at the next step separate patients into groups who may have you may want to target interventions to differentially to kind of change or modify their adherence patterns over time.
Thank you very much.
Thank you.
Yeah. And with that, we can close the session. So thank you all to all the speakers and for everyone for being here till the end of the day. And thank you to my co-chair.
And thank you, great partner, and thank you for your attendance.